Most states do not have a law such as this. Indiana and Virginia were the first to pass this law, these types of laws. But it's kind of amazing that we didn't have a law that said that you had to have a physician present in the emergency department. I think most people assume that we do. Unfortunately, that's not the case all the time. So the law basically says you just have to have a physician present in the emergency care area who is physically there and responsible for the emergency department while it is open, which an emergency department is always open 24/7, 365. So it's very simple, but we didn't have that in place, and it wasn't a requirement until we passed this law.
Welcome to RadCentral, a radiology podcast sponsored by Excalibur Healthcare. I'm Betsy.
And I'm Kiana.
Today we're diving into a major legislative win out of South Carolina that's making waves across the healthcare landscape. The state recently passed a law, South Carolina H.4067, requiring that every hospital emergency department have at least one physician physically on site at all times when open. It's a move that not is just about policy, it's about patient safety, clinical leadership, and integrity of care.
We're joined today by Dr. Katherine Kat Moore, the immediate past president of the South Carolina chapter of the American College of Emergency Physicians, who played a key role in getting this legislation across the finish line. She has previously served as the Government Affairs Committee Chair for the South Carolina College of Emergency Physicians. And today, she'll share how this law came to be, why it matters now more than ever, and what it means for the future of emergency medicine and radiology. Let's get into it. Thank you for joining us, Dr. Moore. How are you doing today?
Thank you so much for having me on to talk about this issue. I think it's really important, and it's not going away.
Well, congratulations for the win. Absolutely. I would like to just start off by saying or asking, tell us a little bit about yourself and what your role is in the South Carolina College of Emergency Physicians.
So I'm a board certified emergency physician. I was a little bit of a non-traditional medical student, so I didn't go back until a little bit later in my early 30s. So I've only been out practicing a little over 10 years now. And I got involved with advocacy pretty early on. When I was a resident in South Carolina, I got involved with ACEP and was able to go to DC for our advocacy conference and kind of got the bug for advocacy within emergency medicine and how we can kind of advocate for our patients and advocate for our specialty pretty early on. And since that time, I've pretty much been involved with our state chapter of the emergency group, which is the American College of Emergency Physicians. So that's pretty much, how I've been involved. I got involved, just as a member at large initially, and then on the board. And then, it's a pretty small chapter. So people who tend to show up and do things. And if you show up long enough, the joke is, eventually they'll make you president. So pretty much that's what happens. So we kind of have a executive branch and we kind of rotate through. So I was the president this last year, which is a 1-year session. And we just switched over. So Dr. Kelly Johnson, who is a great friend and colleague of mine, is now the current president. And I'm the immediate past president, and we still have a pretty active role. And again, there's a group of us that just kind of show up and do things because we care. So, that's pretty much how I got involved.
That's wonderful. What does this new South Carolina law require? And why is it such a big deal for emergency medicine?
Most states do not have a law such as this. Indiana and Virginia were the first to pass this law, these types of laws. But it's kind of amazing that we didn't have a law that said that you had to have a physician present in the emergency department. I think most people assume that we do. Unfortunately, that's not the case all the time. So the law basically says you just have to have a physician present in the emergency care area who is physically there and responsible for the emergency department while it is open, which an emergency department is always open 24/7, 365. So it's very simple, but we didn't have that in place, and it wasn't a requirement until we passed this law.
So why is this law necessary now?
So there's a growing trend to staff emergency departments without a physician present. And there's actually a great study that came out right before we started this process. So it worked really well for us because we could use the study as an example. But basically, it was a survey of all of the emergency departments throughout the United States. And what it found is that 1 in 13 emergency departments don't have a physician present at all times. So that's, I don't know the numbers, something around 80-something% that don't have physicians there. And thankfully, in the state of South Carolina, we didn't have any emergency departments that didn't have a physician on site. But many other states, especially in the more rural areas, don't have physicians on site. So there was that study that came out that showed the need for this legislation. And then 2 other states had passed similar laws over the last year that really helped set us up for success because we already had model language. And so we kind of piggybacked off their language that they used to kind of, write our own legislation.
Wonderful. When was an instance that you first noticed that you needed this kind of regulation? What was going on in emergency departments?
So I think, there's a few things that have happened over the last 10 years, some more gradual and then kind of a more rapid shift around COVID, which, it's kind of a cliche at this point, but so many things changed, and COVID shed a light on a lot of things that were maybe already happening before, but then accelerated during the pandemic. And, as the departments got busier and as emergency care has evolved as a specialty, it used to be that we just saw mostly emergencies, heart attacks and strokes, but really because of the access to care issue, we're seeing a lot more primary care, underinsured patients, urgent care type stuff. So, as we became more busy, the hospital systems basically started to hire more kind of these non-physicians to kind of take care of some of this fast track stuff, which is fine. But I kind of noticed that instead of sitting with one PA or NP and collaborating, it was, 3 or 4. And, we weren't talking anymore. There wasn't any communication. And it became more of like me just signing charts and, even though I'm there, it's becoming harder to supervise. And then I think the way reimbursement is working with insurance companies and CMS and, a lot of shifts there, that there's really this bottom line issue, right? So hospital systems are trying to save money. And you're getting a lot of corporate takeover. So around 2017, the group I was working for at the time was a contract management group, and that got taken over by private equity. And I did notice a shift in our scheduling, like they cut back on the physician hours and increased the PA and NP hours so that we were supervising, more. It was more than not just 1-to-1, it was like 1-to-2 or 1-to-3, which financially makes sense, right? But that's kind of a gradual shift that I saw throughout the 2010 to 2020. But really in the emergency department, when you're doing a lot of procedures, telesupervision really isn't the way to go. But we kind of saw this trend towards wanting this telesupervision, so it's not new, this like telesupervision, but I think it's just becoming more utilized, which can be a good thing, but I think in some instances can lead to some big problems, especially in the emergency department. So I think those 3 things really kind of made it really obvious that we were going to need this legislation to preserve a physician's presence in the emergency department.
I find it interesting because your story could be very identical to other like-minded doctors and physicians who also saw the same trends, but could be on the other side of the country or another part of the world. So your story could very much so resonate with other doctors who've seen that decline in the early 2010s to COVID to post-COVID. It's very interesting.
Yeah, I think, technology is great. We just need to make sure it's used well.
Are there any key differences between the state's laws that were passed? I know that yours went into effect immediately, and there were some delays in getting theirs active.
Yeah, I was really pleasantly surprised how well our basically process went. I think in Indiana, and that's pretty much, I've talked mostly with Indiana group because they're, I've learned a lot about advocacy and how to speak with the legislators and how to speak their language. And I think, South Carolina is a super majority Republican state. So I think using legislation from a state with similar demographics was helpful for us, just so that they could look to, a state and say, oh yeah, we agree with those policymakers. And if they think that's a good idea, then, we feel a little more comfortable getting behind this legislation. So we looked at Indiana and their law, which basically says almost identical to what we have. I think they had a little pushback from their hospital associations. At that time, like South Carolina, they didn't have any emergency departments that didn't have physicians. So And I think that was one of the things that we really had going for us in South Carolina too, is that we didn't have to close down any emergency departments or radically change the way hospitals, emergency departments were. Like nobody was going to, no rural emergency departments were going to be shut down because of the law. So it's as I like to say, it's a lot easier it's a lot harder to put the genie back in the bottle, so to speak. So, unfortunately, a lot of states, aren't like South Carolina and Indiana. So they already have these emergency departments that are not staffed with physicians at all times. So it's going to be a lot harder for them. And I think also the other issue, and you'll see in our law, the wording is really important. We don't use board certified emergency physician. We just use physician, because we didn't want to exclude some of our family medicine physicians who are practicing in the emergency department.
I noticed that. Mm-hmm.
Yeah. So we were very careful. I mean, obviously, as a board certified emergency physician, I think the board certification is important. But because emergency medicine is such a new specialty, really only a little over 50 years old, we still have a lot of family practice docs who are practicing. So that was kind of an important part of the language. So I think Indiana had a little more pushback from the hospital associations. I was kind of surprised that we didn't, because I know that there is a very large hospital system in our state that was planning on opening some of these urgent care emergency room kind of hybrids and staffing them without physicians. And I've heard since the passage of our bill, they may have been taken a little bit by surprise. So I think the timing was perfect. But yeah, I was kind of surprised we didn't get more pushback from the hospital associations. Might
I suggest that they were not paying that much attention to it and were caught by surprise, that someone should have been paying attention to laws and wasn't?
Yeah, I think, that might have been a little bit it. We did have one of the other bigger hospital organizations in the state that actually came to testify to the Senate Medical Affairs Committee with us in favor of this law. So that was really helpful. So we had one of the big systems come, but it was really helpful for us that we didn't have a lot of pushback from the hospital associations. And I think it was a little hard because the way we framed our bill was not a scope of practice bill. South Carolina currently does not have full practice authority or unlimited, so our PAs, NPs, CRNAs still are in collaborative practices, so they have to have supervision. There are a host of bills that have been introduced by actually a senator out of Beaufort, Tom Davis, who really is well-intentioned, but I think unfortunately maybe misinformed about how to expand access to care in rural areas. And his mission is really to extend the practice of these non-physician clinicians. Thankfully, on the Senate Medical Affairs side in South Carolina, we have Senator Verdon, and he's been a huge champion for physician-led care. So these bills have been kind of brewing, but not at the forefront. Unfortunately, we think next year there's going to be some more push for expanded practice or basically unsupervised practice. So we wanted to paint our bill as really a patient safety bill, not a scope of practice bill. So we knew that even the legislators who wanted to push for more expanded practice still wanted emergency physicians. So we really framed that as kind of our talking point.
Do most bills that expand scope of practice, they don't distinguish between the expansion of scope of practice with emergency rooms versus a primary care doctor's office?
They've been pretty vague and not specific. So I think that is the concern. There have been some differences, like the PAs and the NPs currently have different bills that have been introduced. I think that's the concern, is that, these are well-intentioned because they want to increase access to care in these are more rural communities. But unfortunately, we know that doesn't actually happen. Like the AMA has a whole list of, states that have expanded practice. And we know that, PAs and NPs are not practicing in rural areas any more than NDs and DOs are, right? So that's not actually happening. And what's happening is they're opening med spas and having unsupervised, aesthetic practices, because that's where the money is. And then they can work in urban centers, just like we all want to work in. A lot of people, or at least a lot of people, want to work in more urban areas with, all the bells and whistles, the nice schools and the restaurants. So yeah, I think the legislators don't really understand even what what this will lead to and kind of the slippery slope that this opens up. So yeah, I mean, that's our job to kind of explain to them how this could actually affect, essentially making a two-tiered system of people who get to see physicians and those who don't, you know. It really is a patient safety and a patient care issue, which I don't think they fully understand.
I think it's critical that you did put very specific and intentional language in the bill. I find it to be more important than ever, especially in 2025, socially, politically, having specific bills passed that are geared towards the medical industry and the medical field. You do have to have intended language in there to make sure that it's broad enough, it's specific enough. So I think it's a little tricky to be able to master that and get it pushed through the legislation and have it be beneficial for the patients and the doctors involved.
Yeah, I think first of all, we had some great language from Indiana. And we also, we hired a lobbyist basically who kind of helped us navigate that. The chairwoman of the 3M committee basically is the one who helped write this legislation and championed it. And she was fantastic. And so that really helped us. And now I feel like I actually know these people. I know people on the medical affairs side. I know people on the Senate side, as well as on the representative side. So that was a huge key, is like actually getting to know them, telling them our concerns so they can understand that we're not just protecting our turf and, money hungry doctors, that we actually really care about our patients and our practice. And we're all here doing this as volunteers because we care. And I think once they felt that and understood that we were coming at this really well intentioned, and we developed those relationships, and we could actually give them specific examples of things that we were worried about happening and things that we were already seeing, that they hadn't even thought about these things before. So I think that was really helpful. And I think the emergency department is basically the canary in the coal mine, right? Things happen to us first before other specialties. So I think if we can kind of start to get a grasp on this, it will help, in other specialties, radiology and other, everybody has to access the emergency department at some point. And I think when you talk to your legislators and go, when you're having chest pain and you have to go to the ER, you're going to want to know there's a physician there, right? And everybody will say yes. They want to be treated by a physician. So it's kind of an easy example to give, and it's something that most people can relate to. As complicated as our medical system is, everybody can kind of understand the emergency department.
Are you being approached by people from other states looking for ways to get similar things passed in their states? When the people you had dinner with start hanging out with their network and they're not necessarily in South Carolina, is there interest in the bill that was passed? And are there ways that you could offer them a playbook to pass the similar laws in their state?
Yeah, I'm definitely talking to, the community of emergency physicians is, where there's a lot of us, but the community is pretty small. So we have our big national meetings and we have our legislative day in DC every year. So, and the people who do this. And so we kind of all know each other. I know a lot of people from Illinois. I trained initially in Illinois, and Illinois is trying to pass a similar legislation. And so there's a bunch of states that are currently trying to do this. So I have gotten some questions about, what worked for you? How did you do it? I think, honestly, the best thing we did was getting to know our legislators. And then the other thing is, it costs money. Hiring a lobbyist, it does. It costs money. It was really money well spent for us, but that's part of the process. So I've definitely had other emergency physicians from other states. Thankfully, ACEP National has a great kind of collaborative network that we all share our wins and share our legislation. So we're not all just like recreating the language or recreating the process, because every state is a little different, but in general, things are very similar. So we can kind of use what worked in Indiana to work in South Carolina, that might work in Illinois, and some things that work, in our state might not work in California, just because the different, makeup of the lawmakers. There's a big study out of the VA where NPs and PAs do actually practice independently in the emergency department in a lot of cases. And the studies show that actually they cost more money, and they order more, and they have worse outcomes. So we're starting to get studies.
Is that the Dr. Chan out of Stanford? Yes.
Yeah.
I was reading that, and I noticed that it was a working paper.
Unfortunately, we haven't actually really studied this because it hasn't been that long that states have passed expansion of scope. So we don't have a lot of data, and the data that the groups use, that the NP and the PA groups use to support unsupervised practice, really comes from a time that they were very well supervised. So it's a little misleading when they say their outcomes are just as good, because I'm like, your outcomes were just as good when you were well supervised. So there's really not a lot of studies out there with completely unsupervised independent practice. So I think it's a little bit misleading. You know, the studies are only as good as the studies, right?
Mm-hmm.
So being that this legislation came out May 12th of this year, 2025, would you say that this legislation being introduced to your state as well as others, would you call it proactive? Or do you think that the hospitals were already having a hard time to meet physician coverage?
For us, I think it was definitely proactive. You know, South Carolina has a lot of rural pockets, but geographically, it isn't as hard. Like, we don't have huge mountains or, you know, these kind of hard to get to areas that are more rural where we don't have, you know, physician availability. And with, you know, with locums and things like that, you pretty much our emergency departments are well staffed by physicians. We also have 5 training programs within our state. So South Carolina now has 5 EM residency programs, and they're each, I think, having at least 10 residents a year graduate. And those residents, a lot of those will stay in the state and practice. So we are very confident that we can meet the needs of, you know, the growing population and the growing number of emergency departments. Now, I will say, a lot of the hospital systems are opening these freestanding or standalone emergency departments. And I think in some cases, those are great for patients. Like, they provide an emergency department that is closer to them in these areas that have access to care issues. I would say, though, that now some of them are really just kind of a way to get a share of the patient population. You know, you have these systems that are competing. South Carolina just got rid of their certificate of need, which means that, you know, you don't have to get approval to open a freestanding emergency department. You can just, if you feel like it's financially going to work for you guys, the system can open the freestanding emergency department. So, and that just happened a couple of years ago. So what you're seeing is there's these competing hospital systems, right? And I'm not going to name them by name, but if you live in South Carolina, you know who they are. So, you know, and they're competing for the patient population, right? And so I think these freestandings are just kind of a way to capture that patient population more than it's an access to care thing, you know. So I would say that if they're opening so many emergency departments that they can't staff them with physicians, maybe they don't need to open that freestanding.
That's great marketing. Yeah. Yeah.
Good catch by you. From your perspective, how does this legislation enhance the diagnostic workflow between emergency physicians and radiology teams?
So I have a lot of great examples of.
Do tell.
So, you know, I think just in general, and this law maybe doesn't specifically, you know, help with this, but I think in general, this idea, this practice of algorithmic medicine, of using order sets, which I think is great. You know, we want to cognitively offload when we're in the emergency department. So, you know, we're really busy and we don't have to remember like the dosing of heparin and the dosing of certain medicines. So it's nice to have order sets that have these things in there for you so that you don't have to think about it, right? But that can also do a lot of harm and lead to over ordering. So when you have non-physicians and physicians too, but like really like non-physicians who are ordering these greet orders or these like triage orders. So you have somebody, let's say you have somebody come in with altered mental status. You have an order set for altered mental status. And that order set includes a head CT, a chest x-ray, an EKG, these labs, a troponin, and all of these things, right? Fine, you know, it's nice to have all those access, but does every patient with altered mental status need all of these things, especially like a head CT, right? You know, just for instance, you know, I had a woman come in by ambulance, a young woman. She was intoxicated. She was found, you know, on the ground in the bathroom at a bar, you know, in the middle of the night, right? Yeah. So, you know, she came in by ambulance. I saw the ambulance when they came in, and I knew she was coming in. So I signed up for the patient. The patient hadn't been put in a room yet. I went down with the patient to the room, was able to fully evaluate them, and realized that this patient really was just intoxicated. She just drank too much. She didn't have a head injury. She didn't fall. She didn't need a head CT. She didn't need a chest x-ray. She didn't need anything really except to sober up and maybe get some nausea medicine and some fluids, you know? So really, she didn't need much. And so I saw her, I evaluated her, I went back to my seat. And because the pressure to put these door to order times in, which is really a CMS government thing with, you know, numbers and metrics, is so, because there's such a pressure to do this, the PA, who had not evaluated the patient, because I had been in there the whole time, so I know that nobody else had been in that room, had already put that order set in. She just clicked all the boxes to get orders in. So I came back, sat down on my chart and saw all these orders, and I was like, this patient doesn't need any of this, and unclicked everything. But had I not been able to do that, that patient would have gotten a head CT, a chest x-ray, all this unnecessary imaging, right? So that's just a perfect example. And over and over and over times a gazillion every shift, right? If there's a busy shift and there's a bunch of people in the waiting room, you know, these orders just get done without a proper physical exam. So I think that's one way that we're kind of overutilizing, and I know the radiologists hate this, and the techs hate it too, right? I mean, I have literally gone to the CT scanner to pull people out of the scanner going, they do not need that CT abdomen pelvis. They just had one yesterday. Like, they don't need another one. So, you know, so, I mean, if that's happening, and you can imagine if you're at like a freestanding emergency department and there's no physician there, and you have some, you know, you just have these order sets, it's really tempting when you get busy to just do the whole order set so you don't have to think about it, right? But where's the physical? Where's the history, right? Like, I was taught in med school that most of your diagnosis comes from your history and physical. Well, you're bypassing that step and just doing these order sets. Like, well, then AI should just replace this then, if that's how we're going to practice medicine, right? Because if you're just going to use an algorithm, like, what's the need for somebody with a brain to actually clinically correlate? So I think I think radiologists, this has a lot to do with the over ordering of, you know, CT exams. You know, they hate it. So that's, you know, and when I teach, I always tell our residents, I'm like, if you're telling me that you're ordering this because it's in the order set, that is a wrong answer. The answer is, this patient fell and hit their head and they're on Eliquis and now they're not acting right. That person needs a head CT. You know, the 18-year-old who just drank too much and, you know, sat down in the bathroom and, you know, is having some nausea and doesn't look right because she's drunk, doesn't need a head CT, right? So you have to clinically correlate and, you know, not just order stuff because it's on an order set. So, you know, that's what we teach our residents. And I think, unfortunately, because of the pressure for metrics and because of how busy we are, I think there's just a pressure to just use these order sets and order everything.
Financial incentives absolutely play a role in pushing for different types of care coming from different physicians and physician assistants. But what would you say to hospital executives that might be concerned about the cost implications of a law similar to like what was passed in South Carolina?
Yeah, I mean, that's a really, I think, tricky argument because we understand the financial pressures. Like, hospitals, you know, they have to keep their doors open. You know, insurance companies are reimbursing less. CMS isn't reimbursing more, and in some ways reimbursing less for some things. So, you know, I understand the financial pressures. But the fact is that really physicians are not the biggest issue in the increased cost of healthcare. There's been a lot of other factors. And what is the goal of the hospital, right? I mean, what they will tell you in their mission statements are, you know, patient care, inspire, you know, take good care of patients, good outcomes, right? That's always their stated goal. If that is truly their goal, then they want the highest level of training for the people taking care of those patients, right? So, you know, I would argue, if you don't think, like, if you're going to build a plane, you're going to have an airport and you're going to build a plane, you're not going to build a plane if you can't afford the pilot to fly it. You're not going to just have the flight attendants fly the plane, right? So if you're building the hospital, you have to budget in the cost of the leaders of those teams, right? And the most important, right, the bedside leaders. And if you can't do that, then you kind of need to revisit your goals and what you're doing and who's making where your money is going. Because I would argue that as a patient, when I go to the ER, these things matter, and I would think that there are the executives and the administrators, when they go to the ER, I know they matter, right? They come in as VIPs. They're going to get to see physicians. So, everybody should have that access.
Mm-hmm. Mm-hmm.
I think it's important that through your description of what your perspective is on this matter, you can feel the passion coming from, I'm backing up the physicians that definitely need the help. As one of the backbones of this hospital, I guess having that advocacy that you stand for is something that I think should be replicated from other states, to be able to have that advocacy, that voice, to have that support in hospitals. Absolutely.
I think, I think we've covered a lot of things. I just think we just have to keep hammering home the point that, this isn't a turf battle. This is really, a patient safety issue. More education is not wrong. We're not trying to undercut, or criticize our non-physician colleagues. And it's not, I think there's some of that argument, right, that it's just a turf battle, but it's really not about that. It's really about who we want to see as a patient, who I want my mom to see, how we want the practice of medicine to really care for the patients. And there's a place for everyone. The population, it's growing. There's a place for everyone. I think there's, it doesn't have to be a competition. I just think that the expertise and the training matters, and we need to preserve that. So,
well, it sounds like you're not caught off guard as much as other people, and we've been happy to report on the South Carolina law, and I think we can wrap up the podcast. I think we've asked any more questions. Do you have any more questions?
No,
Kayla?
I do not.
Is there anything else you would like to say?
Thank you so much for having me, and I really do appreciate the opportunity to kind of give this a little bit of PR, because I think it is an important bill. I really appreciate you guys. Thank you so much. Thanks for what you guys are doing.
Well, thank you so much for joining us, Dr. Moore. If you're curious for more, you'll be able to see updates and the full text of the bill, H.4067, and its legislative history can be found on the South Carolina General Assembly website. We absolutely hope that you enjoyed and found this episode inspirational and informative, just as Betsy and I have. Stay tuned for more exciting conversations on RadCentral. Until next time, take care and stay healthy.
Special thanks to our sponsor, Excalibur Healthcare, celebrating 25 years of teleradiology with a commitment to patient-centric care.